if we don't have any elastics in play, we're not changing the way the maxilla grows. We're not changing the way the mandible grows. But those, at this time point, were the only options that we would have. We would either have to do a really short class 3 elastics, or we'd have to raise the gums. By raising the gums virtually, it would allow us to place a button on that tooth, right? By proclining, the class 3 elastics would actually move forward their maxillary arch slightly. It wouldn't necessarily move their mandibular back. Then I'd be totally fine with that. Always overdo the amount of expansion and arch development. Okay, so here's our first case. This patient is a 7-year-old, 10-month male who comes in and he's biting in an anterior underbite. Now, if we look to his pan, we can see nice eruption pathways for all of the teeth. There's nothing that's coming in at a super steep angle. Oftentimes when you have these class 3 situations, you may discover that the lower molars are angled forward and have mesial crown tip, but it's not the case here, which is great. When we look to his ceph, we can see if we're looking at the C-spine that this cuts off part of the head and neck, just with our field of view for our ceph. But you can see that we have a small rectangular vertebrae for C2, or for C3. And what this is essentially telling us then is this patient has lots of growth that's left to occur. So if he's already class 3, we need to be very aware and cognizant of that. When we look at facial profile, we see that he's got a more prominent jaw. And so the reality is that we know what we need to do in this case. We're going to be treating this patient with class 3 elastics at some point. Now, because the molar position here in his initial series of photos is a class 1, maybe even slightly class 2 when we look to his ClinCheck plan, which I'll pull up here as well. And he's a slight class 2 end on. There are some circumstances where you could avoid using class 3 elastics in this first batch. And we'll talk about that. When would you avoid it? When do you use them? But one of the things that you're always going to want to do is check to see what is the first point of contact. Does this patient contact edge to edge and then have a functional shift forward? And because this patient does have initial contact edge to edge followed by a shift, it means that we realize that he's not as class 3 as we otherwise may think. It's the retroclination of these teeth causing the teeth to hit prematurely, right? Those teeth hit, and then he shifts forward into that full-on underbite. And so because of that, and obviously it's a negative overjet, not actually an underbite, but that's the terminology patients will use, that we see that if we can procline these anterior teeth and bring back the lower, so bring forward the upper anterior teeth, bring back the lower anterior teeth, we can probably get this patient out of their overjet right away just through tooth movements. Again, what I don't have a picture of, but what is happening here is that there is that premature contact edge to edge and then the functional shift. So that's the first thing that I'm going to be evaluating. So let's go ahead and take a look at this patient's teeth in 3D and look at the ClinCheck. Okay, so let's go ahead and turn on eruption compensation so we can see the spacing of these adult teeth. What we notice when we look at the spacing around the teeth is, again, there's that premature contact with the functional shift, but when we actually evaluate what's the expected width of these teeth, this is the very beginning. This is at tray number 1. And what we see is that there is space around the lateral incisor to this eruption compensation of what the estimated size will be of the permanent canine. There's a little bit of space around the upper lateral incisors here, but we have more spacing that's on the lower. So as we consolidate that spacing here and the teeth retract slightly, what's going to happen is we're going to change the anterior position of those lower incisors just through space closure. Now that's going to help us because if we're making the lower arch slightly smaller, right, and those teeth are pulling back, well, obviously if you're starting off with an anterior negative overjet, as those teeth pull back, that puts us even more into an edge-to-edge position, but we know that first contact was edge-to-edge, so as we do that, we're likely going to see some correction of this situation just through that tooth-borne movement. Now, one of the things that we will often plan, and I'm not even looking at the attachments just yet, but is, let's look at the upper for right now, is creating space, again, dentally on the upper, both for the larger erupting canines that we have, but also just to give more overjet in general. Because when these adult canine teeth come in, and let's just jump ahead to the time point that they do come in, where we can see the larger teeth, and we can see that even if we create extra space around those teeth, we can close this extra space that we created, now utilizing class 3 elastics to pull forward the posterior teeth. Right, so this space that we create, I don't really care if I create too much space on the upper arch by proclining the teeth more than what's needed and creating more space around the adult canines, because we can close that space later. It's not a big deal. So the takeaway I want you to have from this right now then is, even though we have these spaces on the upper right now, it's not a problem. Let's straighten out the incisors. Right? Get the central incisors straight. That's fine. Get the lateral incisors straight. Get the teeth into the proper position, but create space around those primary canines and create lots of extra space. Right? 1.5 millimeters. It could have been even more. We could have gone 2 millimeters. Just get this patient out of any traumatic occlusion. When you look to the initial position of the anterior teeth, again, you can see that the teeth are very flat. And so by proclining the teeth, we're actually giving a better emergence profile and a better torque of these teeth as well. In terms of other things that we're going to do on almost all class 3 cases is we really want to ensure we have enough expansion. Right? Class 3 cases are usually from the tongue living more in the floor of the mouth and the tongue isn't rising to the palate. And so the lower arch is nice and wide, it's fully developed, whereas the maxillary arch usually has crowding because the lips have pushed backwards and the orbicularis oris and the buccinators have pushed in, and that's constricted the arch. Now, in this case, with this particular patient, we don't look at this and say, wow, this is a super constricted maxillary arch, which oftentimes in these class 3 cases, that's what you will see. But we definitely want to widen the arch, because if we can widen the shoe, so to speak, you undo the laces and you widen the shoe before the foot goes in, well, that's going to give enough coordination between the maxillary and mandibular jaws. Right? So right now, this is pretty straightforward and simple, because all we've really planned to do is, on the upper teeth here, we're proclining the maxillary teeth. On the lowers, we're slightly pulling those teeth back to use some of the space that we have available from that canine. Okay, and then in terms of the maxillary width, the transverse, we're expanding the arch. So we're asking for lots of expansion, which again is consistent in almost all of these growing patients. So if we show where we first start off to where we're currently at, or if we look to our arch width table as well, this will also tell us this information that we started off with an initial width of 39.8 between the upper, or that's on the lower, let's look at the upper here, 44.2 on the upper, up to 48, so that's almost 5 millimeters of arch development and expansion. We're not expecting that we're going to accomplish all of this, but it's something that we're planning in every single class 3 growing patient case. Now, what I could have certainly done in this case that you're going to notice I didn't actually do is I actually did not use any class 3 elastics. Let's go to the attachments at this point now, just to see what we actually did. So we certainly could have added class 3 elastics, but because his primary teeth were so wiggly and about to fall out on the lower, so both of these two teeth were very mobile, so we electively had those teeth extracted. You can see how much of the, or not extracted, sorry, but we let them fall out on their own because the root has mostly been resorbed prematurely by these lower canines. So the problem with this is that we run into an issue. And the issue we run into is we can't put a button on those lower canines because even if we could, the teeth are going to fall out anytime. Now, one of the things that's quite annoying is that we can't actually put a slit. If I go to modify plan, and I won't be able to modify the original plan, unfortunately, but if we go to modify this plan and we want to place these slits into the lower canines that have the eruption compensation, as we grab on these lower slits and drag them over, it's going to tell us, it'll show an X like it currently shows. Now, right now it's showing the X because there's already a slit. But it will not allow you to actually place that precision cut on eruption compensation. So our choices then are, let's just go back to this version of it. We could go ahead and place a precision cut, a slit, from the lower first primary molar, or we could actually virtually raise up the gingiva on this tooth and then place a button here. But those, at this time point, were the only options that we would have. We would either have to do a really short class 3 elastics, or we'd have to raise the gums. By raising the gums virtually, it would allow us to place a button because virtually changing the cut line would allow us to place a button on that tooth. Now that might not make the most sense. Let me explain this in a different way. When Invisalign gets made, the way that it gets made is that it goes around each individual tooth. It's called a scalloped cut. And so one of the things that Align does not let you do on these patients where we want buttons on the anterior is they do not allow you to place buttons on incisors. It's just not an option. And so if you want to place a button on an incisor, you either need to take a hole punching tool and punch all the plastic trays to then go ahead and punch every single one of their entire series to place a button on the anterior teeth, or you could ask them to change where the gums are on the teeth, where the software automatically had detected the edge between the tooth and the gums. Because if we get them to change the cut line here so that it doesn't cover as much of the tooth, so let's say you want to put a button on this lateral, but you can't, you can ask the technician to virtually raise the gingiva so the gum height changes. That's going to give you room now to place a button, because instead of having the trays trimmed to where the actual tooth ends, they're trimming it slightly further down because it thinks that this area here now is actually gums, and the trays don't cover the gums. And so that's how we can actually glue a button onto a tooth that normally isn't allowed to have a button, just like you see here. Because this is actually where the tooth ends, but the trays are going to be trimmed to where the gums end. So I hope that makes sense. The main point of all of this is just to say is that there's ways that we can work around these problems. One thing that's going to be really, really nice is right now Align is in the final stages of their beta test for having the integrated button directly onto the aligners. So we won't have to do this anymore where we virtually raise the gums because we're missing a tooth and we need it to be on a different tooth. We'll actually be able to hook the elastic slit directly to a button on the tooth or on the tray. So the button's essentially being like plastic welded directly to the aligner, which is sweet because it's going to save us from this issue. But what I want you to recognize again from this is that there's lots of different ways of doing this. We could have simply raised the gingiva and placed some buttons for class 3 correction, but our other option was to say, why don't we just go ahead and do a tooth-based movement? So proclination of our uppers, retro or space closure on our lowers, where we're going to have a little bit of extra space, expansion on the uppers. The attachment designs that I'm going to be placing then is anytime that I'm expanding, I want to have nice thick horizontal 3mm attachments to 4mm attachments. So those are getting placed on all of those primary teeth that are expanding. In these growing cases, I almost always use lateral incisor attachments beveled towards the gingiva to help give us control. Now, sometimes I would place an attachment on these central incisors as well, but because I want to give this a shot, it's only rotational movement that's really happening here, I said, let's not place anything on the upper incisors. Although if we had wanted to place something on the upper incisors, it would not have been wrong because it would just help make the movement more consistent. But in terms of the attachment designs here, you can see this is quite basic. Some horizontals in the posterior to help with the expansion, And then we have lateral incisor attachments. I could have certainly placed some attachments on the lower laterals and incisors here just to help with some retention, but I didn't. Okay, so one of the other things that I want you to recognize here is that one of the things you'll notice on the bottom section here is these little cross slashes going over top of the numbers. And this is currently showing it then going through the entire series. And what this is showing is it's indicating that there is a change to the anterior posterior occurring during treatment. Now, how we can change this simulation is to click on this staging folder at the top. And if we click to bite correction visualization, how I always want this set up is to be at the end of active treatment, because what this is now showing us is it's essentially showing us how much change is happening through space closure or creating of spaces in the anterior versus how much of this is happening through a bite jump, a change to the anterior posterior due to growth modification. Right? So we see this jump happening at the end. Now, what does that mean? Right? Well, that jump is indicating that the patient's starting off here and then it's going and we get out of that class 3 situation, and then it's showing a jump even further going to give us more overjet. But if the patient just simply wears aligners, so you put an aligner on the top and you put an aligner on the bottom, as you go ahead and you correct the movements from dental, so proclination and retraction, and then all of a sudden we see a jump, what is modifying this patient's growth? What's altering and changing it? Because in reality, if we don't have any elastics in play, we're not changing the way the maxilla grows. We're not changing the way the mandible grows. Or we're not using a headgear or a reverse pull headgear. We're not using any intraoral appliances that are changing the way that patients grow and bite, right? And so what ends up happening then is that, well, we're seeing a change to the growth pattern. That's what that jump represents. That's growth. That's being modified. But the aligners themselves don't do it unless you're in a class 2 situation and you're using the mandibular advancement little tabs or you're using the occlusal blocks. Other than that, it's the elastic rubber bands that create the changes. And so what I want you to recognize here is that in this plan, where I currently show here's all the changes of here's all the tooth-based movements, realistically speaking, this jump at the end, jump of whatever, 1 millimeter, 2 millimeters, it is not actually realistic to occur other than, remember how we said this patient had a bit of a functional shift, right? They were biting and then they were sliding back. We could have set up this ClinCheck differently. We could have set this ClinCheck up so that we scanned the patient biting edge to edge. Or I could have told the technicians, hey, please set up so that their incisors hit edge to edge, because that's actually their bite position in more of a centric relation position where they actually bite. And then they have that CO-CR shift. So normally that bite jump is just indicating modification to growth, except in this case where we let them set up the bite a little bit further forward because that's where the patient wants to bite. But in reality, we know that if we procline these teeth and the bite comes together, well, this is the position the teeth will want to be in. But if we actually scan the patient like this, further forward anteriorly, as we procline the teeth, and now if they were normally having that premature contact, well then we've artificially allowed their scan to be further forward. So that's why I allowed this bite jump to show, is just as a simulation of not that we're modifying the growth through the use of elastics, but we kind of know that when we set this up here, that's not actually their true bite. Their true bite is about 1 millimeter further back, hitting edge to edge. And so I hope that makes sense as to why this is allowed to show, because again, those eager participants here who are looking at this are going to say, this makes no sense. There's no elastics. How can we modify the growth to back the mandible up? And the reality is we're saying, well, we don't expect the mandible was actually as far forward at the very beginning. So again, please note that we could have just had them scan NCR. We didn't actually do that. But that's why this could just give a simulation as to if we just do the dental movements and their jaw no longer shifts forward into that CO position, this is what we could see. So let's go ahead and take a look then on our next ClinCheck. What did we actually accomplish? And again, I try not to pick out just cases where everything is super basic and straightforward and easy. I want to show you guys the real world because sometimes the real world is confusing and complicated. So let me go ahead and show you the ClinCheck first because this is a scanned position of their bite. Check it out, right from our initial. And let me show you the comparison here because I really like using the comparison feature. Whenever I finish a ClinCheck, I try to go to my comparison to evaluate what did we expect to happen and what actually happened. Well, let's go to the beginning actually. So here's where we first start off. This is our expansion. This is our proclination. So this is everything that it's saying we could accomplish and expect to see without any bite jump through a change to the CO-CR situation. So again, on the right is actually the initial, and you can see it's a pretty tight bite. But because of that CO-CR shift, that's where we said, well, we realistically expect we might have a bit more overjet, and it's just a simulation. We have no idea exactly how much change there will actually be, but when you evaluate from what was given with no bite jump on the right here to what we actually see in the real world is we have a bit more overjet than if we had no bite jump just through the CO-CR correction, but it's not as much as what was shown here. This is probably like 4 millimeters of overjet correction, or like where the simulation shows, whereas we can actually go to treatment plan 5 and let's check. In treatment plan number 5, we can go to the overjet. And in the overjet table, we can now evaluate and we can see that we actually have a 2.2 millimeter overjet at tray number 1. We've created that space of the 8 and 8, and then we've got 1.3 and 0.1. You can see then that this canine didn't perfectly track because we would expect that normally we would have, well, we had asked for it to be 0.8 and 0.8, so that's 1.6. In reality, we ended up with 1.4 of total space, but it, for whatever reason, it expressed more mesial to that canine because this canine didn't track the best. But does that matter? Not really, because this canine is irrelevant in the context that it's going to fall out. A new tooth is going to come in, and then we will deal with that spacing later. So this is what we've actually gotten from our scan. But let me show you something that's confusing. Check this out. So this is what things actually look like when we look at the photos of the patient at this next appointment. Things are messy and things are not clean here because we have two different things we're seeing. We took the scan and we see this bite. We take the photos and we see this bite. So what is the accurate bite of this patient and how do you decide? Well, here's the basic thing. Patients have the ability of changing their bite to go more forward regularly. Like for a normal person right now, you take your jaw, you can stick it forward about 1 centimeter, 10 millimeters. Totally doable, right? Change the anterior posterior position just through the hinge access as well as the translational ability of our jaw. What you don't really have the ability to do right now is to force your jaw back. Now, it doesn't mean that there's never a circumstance where somebody's jaw could be forced backwards. There are numerous situations where patients have a class 2 div 2, they bite, they hit prematurely, and their occlusion and their musculature forces their jaw backward. And their condyle gets pushed backwards on the retrodiscal tissue, their jaw joint pops out of position, and that now causes TMD pain because the tissues on the retrodiscal tissues are highly innervated. So it's very painful, and that causes some joint issues, right? So your jaw could be forced back if your muscles and the occlusion are in the wrong spot. But in this scenario here, is it likely that the patient is able to bite and then they're forcing their jaw backwards into this position? Not really, because we know that if anything else, they'd be hitting edge to edge and then that would be the initial spot of their contact. But when we look just clinically to see where does this patient hit, this is where they hit, right? They're not hit, like usually what's gonna happen is if you're hitting slightly behind and there's not enough overjet, that's what's gonna force your occlusion backwards. But the trays are discluding the bite. The trays are allowing the jaw to go wherever it wants. So the jaw has not been biting for the last 10 years, getting force backwards as they're functioning. Instead, the trays are discluding this patient's teeth. And so if we see them coming together in a normal spot, and we observe that, bite together, and they bite in a normal spot, I'm not thinking that they're hitting and then shifting backwards if they've just been wearing trays for the last 6 months. That's not what's happening. Because if they had been biting like this for 2 years, 3 years, 5 years with no aligners, maybe that could be happening. But in reality, what's happening is this patient still has a tendency, a habit, to posture their jaw forward. So what's important to look at is not just to get the patient to bite together and say, go ahead and bite. This is the equivalent of that patient being in their classic Sunday smile, where you're like, bite together for me, and somebody goes, right, they're sticking their lower jaw forward to get the Sunday smile. Well, realistically speaking, that's exactly what's going on. Now, how can you actually determine this? Because you might say, well, Stephen, I get that you're saying that, but I don't want to cause TMD in my patients. I want to ensure I can correctly tell where the bite is. Well, let's get the patient to bite in this spot here, where they're currently biting. And then what you get them to do is ask them to try and shift their jaw forward more. And if he goes, well, I can't. They can only get 2 millimeters, 3 millimeters, 4 millimeters of further anterior movement, then you know that this is the postured bite. Because normally we have about 10 millimeters of play in the anterior posterior that you can shift your jaw further forward. So if he's biting like this and you say shift your jaw further forward, like try to go more caveman, and they can only go another 5 millimeters, then you know that there's a functional shift at play. So that's why when you look at a bite situation of a patient who's currently in treatment, who's wearing aligners, so they would have deprogrammed their jaw because of the disclusion of the plastic, and you see a discrepancy in a class 3 scenario, where one series of photos shows them biting them normally, and the other series, or the scan or whatever, shows them in a class 3 situation, the more accurate of the two is the one where they're actually biting in a proper overjet situation. So what we really should have done here is probably retaken our photos, getting the patient to bite on their back teeth. But again, the real world is messy. Sometimes you're behind. We got the scan. I look at the scan. I say the scan looks good. That's actually where their bite is. So I'm not going to be super worried about the fact that their photos show them in class 3, because I understand the diagnostic information to recognize that this is the correct position. So hopefully you understand that, but even if you don't understand it, the main thing you can just take away from this is if you have a discrepancy between the photos and a bite, you're always going to want to take the more posteriorly positioned jaw situation. That's probably the more realistic position of where they're actually biting, because we know they can shift forward just through muscles and through habits, or for whatever reason they just postured during the photos of the scan. But it's really hard unless you had something significant like that class 2 div 2 bite forcing their musculature back. It's very unlikely, partway through treatment at least, that they're biting and then they're shifting backwards. And again, the way you determine that is just get them to do that anterior posterior shift, see if it's a lot, see if it's minimal, and that will give you a better idea of where they're actually biting. So, needless to say, this is where we're at. Now, here's my question to you. This is now your biting situation. What do we need to continue doing at this point? What is needed for active treatment? Right? The patient has a decent overjet. We have spaces around the canine for the eruption of the adult canines on the upper. The lower still have the permanent canines are coming in. We've widened the arch. Just for fun, let's go ahead and compare actually what our arch width was and what our arch width is. Although I think I will have to go in here to our, oh no, perfect. It does show plan 3 and plan 5. So we started off with an arch width between our upper canine and canine of 44. We tried to expand it to 48, and we got halfway there. We went from 44, instead of going to 48, we went to about 46. That's pretty common. You're going to get about half of what you ask for with your arch development and expansion. So always overdo the amount of expansion and arch development. But if we've corrected the overjet, we have space for the erupting teeth, and we fixed the transverse, or at least improved the transverse, is there an immediate need for this patient to continue wearing their trays full time? Well, the answer to that, in my opinion, is no. They don't need to wear their trays full time because at this point, all the main things are corrected. If this patient showed up to my practice right now and was referred over from one of the associates, I would probably say you don't really need treatment just right now. You've got space for your erupting teeth. You've got a wide enough arch. You don't have any anterior premature contacts causing damage to the teeth. You're good. So what we can do is we can simply put this patient into nighttime wear now. They don't have to wear their trays full time, just have them wear them at nighttime. Right? We can go ahead and maybe create a bit more symmetrical space for this canine. We'll allow the eruption of this lower canine, but still maybe create a bit of space around it just because we know that the tooth is slightly wider under the gums right now than above the gums. So we're going to do that. We're going to do a bit more arch development, but for the most part, we can just leave on some of these primary tooth attachments. We've lost a few of them. Who cares? But we're just going to get them a batch of trays at nighttime just to wear because that's all we really need to do right now. We're just waiting. And so what do we see come back into our practice then? Well, we give it a year of just wearing trays at nighttime, and here's the patient. We have eruption of some more of the adult teeth. Still got some space distal to that canine tooth. We're maybe a bit tight on the overjet here. We certainly could have had this patient wearing class 3 elastics at nighttime, but if we look to the facial balance of where we first started, right, we see the upper lip slightly retruded, but as we procline those teeth, that helps. As we slightly retrocline those lower teeth, that's going to help as well. So after his first series of trays, this is what his facial profile looked like. It was much better. So even at progress right now, yes, he has more of a class 3 tendency on the jaw, but when we look at the facial balance, it's pretty good. Now, this is the nice thing about starting early enough because this kid's only 10 and a half years old right now. So we have lots of time to add in class 3 elastics as needed still, as long as he's not biting in traumatic occlusion. We are I love this analogy. We're at the airport early. The way I look at things is we don't want to miss our flight. You're flying from Vancouver to Europe. You don't want to miss the flight, so you show up early. And when you show up early, you get through security, you get through customs. Now you can go sit in the lounge for a few hours. And if you're worried that you're going to miss your flight or you just want to be cautious, go to the gate and sit there and wait. Right? You don't have to wait till it says boarding to go sit at the gate. You can do that earlier. So right now at this point, we look at things and we say, you know what? He's getting a bit tight with this overjet. We were better before. Well, we weren't because of that. But if you look to his ClinCheck, we were better before, but it's looking a little tight. Maybe the lower jaw is growing more. Oh, maybe I'm wrong even here. I thought we started using some class 3 elastics at this point, but right. So the canines erupted. The lower canines now are fully in. We've got that extra space around our canines. We still have our primary teeth here, so we know that we're going to have more space on the lower because the erupting primary or premolar is going to be large or smaller than this primary molar. Right? The primary molar is really big. The premolar coming in is going to be smaller than that. Same thing on the upper, but not to the same extent because look how much bigger that lower primary molar is. And so why we didn't actually go to the gate just yet and start using some class 3 elastics, even though we're getting a bit tight, is because we know we're still going to lose these primary molars. And we're going to have extra space on the bottom where we can retract these teeth into that space as needed later. So it would have been totally fine to use some class 3 elastics right now and give ourselves a bit more overjet. And I would say it looks worse. It looks a bit tighter in the photos than it does actually on the ClinCheck. But what's great about this is just to recognize that you can go either direction. You could use some class 3 elastics right now, give yourself more overjet, and just do it at nighttime. Or you could go ahead and you can wait. There's no right, there's no wrong. If I was doing this again, I probably would have thrown some class 3 elastics in a bit earlier, to be honest. But I didn't. So what does that mean? Well, what are we going to do here? We're simply going to make sure that we have enough space for the canines to come down. So a little bit of eruption of those canines. Now, as we close the space around this canine tooth, the anterior teeth are going to slightly retract. The posterior teeth are going to slightly move forward, mesialize. But it's not helping our overjet if these anterior teeth retract, which is again why I would likely just pop on some class 3 elastic to slits in the trays that he would just wear at nighttime, but I didn't. And in this time, the trays don't fit as well as they should. Maybe he's not wearing them as much as he should. We've now lost some of our primary molars. So the premolars and all the adult dentition is now in. But you can see as the teeth come in, we have lots of spacing around the teeth. Because we know that leeway space, this is showing IPR that's going to be occurring to tighten up contacts, but you can visibly see, just visibly look between the teeth and you can see these spaces. Unfortunately, if you plan IPR, it doesn't tell you what the residual space is. But so what we're doing here is we're not planning this IPR because we actually want to do IPR. We're planning it in just to tighten the contacts a little bit more. So you can see all the teeth are in. The patient's molar situation is they're slightly class 2. Same thing on this side here, we're actually slightly class 2. So again, I actually did not plan in any class 3 elastics at this point. We simply just focus on closing those spaces, leaving the molars in that slightly class 2, pretty close to class 1 though, position. And just doing this at nighttime. We're not doing it full time. We're literally just doing it in the nighttime. And again, if you'd wanted to give more overjet, based on the photos here, is it inappropriate to use some class 3 elastics to give more overjet? Well, I did just say that this patient's slightly class 2. So why would we use class 3 elastics? Well, here's a question for you. Would you rather have a little bit more overjet or a little bit less overjet if you had to pick? And you've got to pick one. More overjet or less overjet? What are you going with? Well, the reality is for me is that I do always want a little bit more overjet than less. Because we know this patient still might have some jaw growth coming later. And we know that if we're too tight, we do have the possibility of hitting, forcing the jaw backwards. So I'd rather have more overjet than less. And so because of that, if we had again planned at any one of these points to use class 3 elastics to make the patient slightly more class 2, right? By proclining, the class 3 elastics would actually move forward their maxillary arch slightly. It wouldn't necessarily move their mandibular back, but it would procline their maxillary teeth. Then I'd be totally fine with that. But again, I'm here to show you, we didn't. All we did is we focused on closing those spaces. So let's go back to our photos. You can see here, we've got some spaces around the teeth. We've got a nice arch width on the maxillary. The mandibular looks good too. Again, at this point, we've only done 6 months of full-time trays. Everything else has been at nighttime. So this is what we go ahead and plan in our last ClinCheck then. Because we want to ensure a bit more overjet, we are a bit tighter. We're going to focus then on, at nighttime, putting some slits on the tray and giving ourselves a little bit of class 3 correction. Now, I actually do not show a bite correction visualization, so a change showing a bite jump. It's just simply the fact that I'm having this patient wear those elastics just at nighttime. We could have had them show a bite jump at the end here. I remember that jump that we had from our first batch, which was more of a jaw repositioning due to the functional shift. Back to our staging, bite correction visualization. At the end of active treatment. Here we go, there's that little jump. We could have shown that same thing, which again is just indicating modification of growth from the use of elastics. But we didn't. That's fine. But all we're doing is bringing those teeth and settling them a bit more. One of the things we can evaluate in terms of the classification of the bite is the Bolton analysis. The Bolton is essentially telling us that the lower teeth are a little bit wider than they should be. Now, normally Bolton is relevant if it's more than 2 millimeters. This is not 2 millimeters. So when we're looking at this from a numbers perspective, I would say we don't need to do any IPR But if you actually look at how the teeth are biting together here, you can see that the overjet isn't huge, but yet we're slightly class 2. This is where I think it's important to sometimes look at the actual ClinCheck in front of you. Because if we wanted to, let's make a modification to this last plan here. If we wanted this patient to be in the best class 1 occlusion with the best overjet, we would actually potentially want to add in some IPR here. So if we added in some IPR, and again, remember any of this previous IPR is not real. We did not actually do any of that IPR. But if we were to do some IPR to give ourselves overjet, to make the lower teeth slightly smaller, and we were theoretically to move these teeth back to put them into the perfect class 1, this is the patient actually in the most ideal occlusion. Now, our table isn't telling us that we have a significant Bolton discrepancy. It's telling us we have a minor Bolton discrepancy. But if you actually look at the teeth, look at the bite classification of this class 1 versus class 2 situation, I would argue that theoretically we should add in some IPR. But here's the whole debate again is, do you go in and do some IPR, removing tooth surface, pulling the lower teeth back slightly to give a better occlusion in the premolar and molar region, and then needing to do IPR in the anterior so that we don't have too tight of an overjet in order to make this slightly, I guess, better? Or do we recognize the fact that this patient here is biting slightly class 2 in the molar region, but we do have the correct overjet? That's always the debate. Right? Orthodontics, even in these growing patients, still is sometimes a compromise of, do we jump in and remove some tooth structure, even though the Bolton analysis does not tell us that we have a significant Bolton, in order to allow our molar position a bit better? Or do we say, no, let's go ahead and leave things? I don't think that we're at the point where there's a completely right or wrong answer. Because let me go ahead and show you where we're at then after this series. And again, you might look at this and criticize and say, well, Stephen, you should do it differently. And we're not completely done with this case. We're still monitoring to see now where is this patient at and what do we need to do for more adjustments? Because you can see the mandible has grown, or there's a slight CO-CR discrepancy where the patient's slightly sliding their jaw forward. But you can see that the molar occlusion here looks really good. I did not do any IPR there. All I did was, again, utilize some class 3 elastics. But if you look at the overjet, we are tight. We don't have a ton of space there. And so we need to be aware of one last thing with this case that's really important. We either will still have to come in and put some IPR in the lower later, like we talked about, if we're concerned with any jaw issues, with any TMD or occlusal issues that he's hitting prematurely on those anterior teeth. And we still will want to have this patient wearing class 3 elastics from their lower canine to their upper first molars at nighttime. Because this patient is now 13, we know that he's going to still have more growth. We don't want to just allow this kid then to grow more in his mandibular dimension, more in the anterior mandibular situation than his maxilla. And so the last thing that I will tell you about this case is that what we want to continue doing is we do want to continue giving this patient class 3 elastics that he just wears at nighttime. Because those class 3 elastics at nighttime will help promote more maxillary growth. It's redirecting the growth of the mandible into the maxilla and trying to restrict as much mandibular growth as possible. We're not going to use super heavy elastics, but we would look to use something like maybe a 3.5 ounce elastic or a 4 ounce elastic just from slit to slit, just like you still see here. Something like this just at nighttime, even though everything is perfect, all the teeth are in, the second molars are in, the contacts are good. I would not just say, okay, cool, see you later, you're done your treatment. I'm actually going to keep this patient in these aligners with class 3 elastics running at nighttime until we get to the point where we're confident that the majority of this patient's growth is finished. Now you might say, well, Stephen, seems like a really complicated case. But in reality, it's not. What did we do? Well, to start off with, we just recognized the fact that this patient was biting edge to edge. That made this a lot easier. We proclined the maxillary teeth, retroclined the mandibular teeth. We used some attachments. They could have been any attachments whatsoever in the posterior, and we did arch development and expansion. 6 months. Then we went ahead. We didn't use class 3 elastics at nighttime, but we certainly could have. And we did almost no movements other than just very tiny tweaks. Come back a year later again. Here's where he's at. Same thing. We actually didn't do any class 3 elastics. Come back another year. Now we go ahead and close the spaces and add in some class 3 elastics that are just going to be worn at nighttime. Consolidate the spaces. If we find that he's too tight, we're going to do some IPR on the lower. We can be conservative about this and wait. We don't have to do it immediately. But once we get to that point, then we're now in really good shape for just making sure that this case is not going to jump into a major class 3. But I do need you to be aware that it does take time to do all this. So this patient still has been in treatment for about 3.5 to 4 years at this point. However, only 6 months of that was full time.